Hello, everyone. This is World Federation Neurology World Brain Day team, social media team, and YouTube channel. I am your chair, World Brain Day, Tissa Vijayaratne. I am quite excited today to introduce our guest with whom I have been working almost side by side for a number of years on the back of mutually interested research in relation to brain health and neurology. This is Professor Algis Vingrys. He was the former chair optometry, Department of Optometry, University of Melbourne. He has an illustrious career, but more to the point, he has a unique story. Professor Vingrys, my first question to you, tell us how Algis Vingrys was made to this world. So take us back as far as you want. If you want to start from primary school days, we can start there. If you want to start from high school days, we can go there. So take us back. How did this occur? Maybe I would ask a question. Where were you born and where were you raised during your formative days in your primary school?
Tissa, like very many people in Australia, my parents immigrated after the Second World War. They were called displaced persons, and they were in immigration camps in Austria and Germany, and were being distributed through different places throughout the world. To my recall, my parents wanted to travel to America, the country of free and honey and all the rest of it. But they didn't get accepted, and they got put to a country called Australia, which they knew nothing about. They arrived in 1950. I was born in 51, and we lived as migrants. And one of the biggest things that, as you probably realise, that many of parents from those sort of backgrounds find is that education is an important element. And so my parents pushed me to be educated, but I also enjoyed that element of it, and I went through high school not quite knowing what to do. I'm not sure if you know this other little part of my background, but at the end of high school, I decided to take up professional flying as a career. I became a pilot with Qantas, and I was flying with them for some time. And then they retrenched a whole lot of pilots, of which I was one. And I went back to university and spent time studying science, and slowly moved into optometry. And I found I had a desire for research as well as my clinical work. And I stayed in clinical research with optometry. Interestingly, you may not know this, but my very first postdoc after I got my PhD was in the neuro-ophthalmology department at Ohio State University. So I have a soft touch for neuro-ophthalmology, multiple sclerosis, optic atrophy, many of those conditions are degenerative conditions that the neurologists and the neuro-ophthalmologists worked with back in 1984 to 87 when I was there as a postdoc.
So that's a remarkable story. I think I knew most of the story having read about you in the past. So to give a summary version of your journey to our viewers, you basically come from an unwanted family, so to speak, by many countries, and your parents were trying to go to the dreamland USA, but they were basically literally dumped to this country called Australia that they know nothing about, probably carrying you in your mom's tummy. And then you were born after arrival to Australia within about a year or so time. Many the migrant families, education is a key component. So you worked hard, you educated yourself well, but in the end, you end up becoming a pilot. So you were a commercial pilot to begin with, and then you found your academic, the rebirth, if you like, somewhat later in your life, but that didn't stop you from making an enormous contribution to science. You end up becoming the chair of optometry in one of the very best universities in Australia, which is not an easy task for a faint-hearted man or faint-hearted woman, for that matter, isn't it? What were the challenges that you faced when you come back to uni? I'm assuming that as a sort of a somewhat older student compared to your contemporary students.
Well, actually, when I came back to university, I had just got married. And during the period that I was at a university doing my undergraduate degree, which at that time was 4 years, my wife and I had our first child. And I was at that point still thinking of becoming a clinician, going out into clinical practice. And one of the academics at the university was aware of the fact that I was a pilot, and he wanted me to stay on and do a PhD because at the time there were a lot of interest in vision standards and the requirements of visibility and what pilots can see. And so I undertook a PhD with that academic, and I finished my PhD in what is called visual ergonomics. So it wasn't really in neurology or neuro-ophthalmology. But I had done some programming at that point, and computer programming was quite an important element of generating visual stimuli and then testing them. And so that then led to my appointment as a postdoc in the neuro-ophthalmology department, where I was involved in producing visual stimuli for patients who had MS, patients who had all sorts of optic atrophy levers and a lot of others, as well as degenerations. It was during that period, Cesar, that my clinician came to the fore, because I was dealing in very sophisticated research, but I thought this sort of stuff should be available to everyday clinicians. It's important to test patients. It's important to make sure one has a good grasp of what they're seeing. I used to get so tired of patients coming in to see me, and they'd say, look, I can't see very well, but then I'd give them the acuity chart and I'd go A, B, C, D, and they'd see it. And I go, I can't make sense of this. How can you see that chart and then claim you're not seeing well? And it dawned on me that we were really in the need for simple yet effective yet sophisticated tests. But that challenge, as you know quite well, took about 20 years to come to fruition, where I had been working on a whole of other research projects, and it took about 20 years to finally, for me to join with a very clever programmer, Dr. Kong, George Kong, and he and I have developed a series of apps that are based on iPad tablets, and it can test vision. And our purpose was to allow doctors, neurologists, nurses, anybody to test vision, because the apps produce the sophisticated visual stimuli that are needed for that purpose.
I'll build the context of this to what Professor Vingrys just said, how important this is. I think probably about 5 years ago, a young mentee of mine that I was persuading her to continue a PhD, her main desire was to pick up a PhD in multiple sclerosis. And I was discussing her with one of the other neuroscientists at a different university to see how we can encourage her to pick up a part-time PhD. I was already using some of the resources that her optometry clinic was having to sort out my patients, and then she came back to us one day saying that I think she knew you before, or she met you at some stage, and we were. In fact, by that time, I probably spent almost like $10,000 of my personal money on various devices to see whether we could find a way to measure eye movements, which was what my primary love was at that time. If you visit Sunshine Hospital, my office, you would still see I borrowed one of the patients the lunch table, if you like, which is like $20, and it's a sort of broken the lunch table. You could sort of change the height, and then with another PhD student's help, we mount something to keep some sort of a tablet, and then we were experimenting various ways to measure the eye movements. But the problem for me was while it would have worked very well in a research laboratory to deal with normal people, it didn't deliver to patients who were sick with stroke or migraine or multiple sclerosis or Parkinson's disease. So that 10 grand or so was basically literally, I shouldn't say wasted. I learned a few negative things. But when this particular young mentee told us that there is this application that only takes about 6 minutes to do visual field, I think your group has already validated this against Humphrey device. And I was basically able to literally brainwash her to move away from MS, as we had a lot more strokes at that time, and then the probably build a doctorate on that field. And then we saw something really interesting. It is published now and it is available as abstract also. We saw the things that we did, very simple things that we did using Professor Vingrys and Dr. Kong's app. We were able to show that sensitivity of teasing out whether someone had an undiagnosed stroke or stroke was actually better than doing an acute MRI scan of the brain. And it costs nothing other than the money that we spend for the iPad, because we were given the application free by Professor Vingrys and Dr. Kong, so we didn't have to pay anything. So I think we studied almost close to 200 patients using that application, and it is correct to say that the application is available worldwide, and now a different US company has acquired it and using it in US and a couple of other countries. Am I correct, Algis?
Yes. One of our challenges as a company, we've now started up a company with a group of partners, one being the University of Melbourne, who are my employer, myself, George Kong, and the Eye Hospital. And one of our challenges has been to get the approvals from the various FDA or TGA government regulating bodies to produce these products so the clinicians and the public in those countries can be confident that they are reliable and that they are working the way they're intended to. So we've had TGA approval in Australia for quite some time now. I think it's about 4 years. We got FDA approval about 2 years ago, and just this year we have got CE mark and the new British MHRA registration as well. So yes, we're moving on becoming an international entity, and it's taken time and obviously taking a fair amount of money to get those approvals in place. I think the more people, I've been driven partly, as you said earlier, to make something that's cheap and easy to apply and clinicians can do. One of the very early researches I ever did when I came back from America was in migraine patients, and my interest was to see whether using vision we could actually monitor migraine and monitor the episodes of headaches. And it turns out that got me interested in telemedicine and home monitoring, and this has led to these applications that we're now developing. But the home monitoring of migraine, we have a paper some time ago with some of my colleagues where we showed that if people monitor migraines at home, they can actually predict the migraine onset by about 18 to 12 hours. That's a very exciting finding, as I'm sure you've said to me in the past. And it simply means that now people may be able to pre-treat and hopefully abort, if not modify, the actual headache. And so the actual medications that are needed, the challenge is to find those that will actually help in doing that. And so a lot of the work we've been doing over the last 2 years, as you probably realise, has been not just to prove the applications, but also to make them easy to use so that people can apply them at home by themselves. And the challenge has been that in the clinic, when you get a patient, you usually have a clinical assistant who guides the patient through a test. At home, they don't have that. So we've developed a whole lot of supports, language, audio, movies, and so on that helps patients understand what the test is about, how to do it properly, and then do the test at home in their own right. And these are aimed at chronic diseases, of which neurologists would have a classic example in MS, because it's variable and it comes and goes, and patients can modify or can monitor their own performance in the home environment.
I think you touch upon two important areas. I'll spend some time on this. Let's say that the application that you developed when you do the visual acuity with contrast and without contrast, using either the tablet or desktop. We forgot to tell our viewers that you now have a version that can be run through any computer, if you like. It need to have 4K resolution for the application to work. We tested it with a remote Sri Lankan site on a test person a few years back when we were trying to put together a grant that we didn't get. And it worked very well when we look at the acuity at the chart. So with and without contrast, acuity change seems to be almost pointing towards some disturbance in brain activity. So we'll park that to a side. At this point of time, we get about 16 million strokes per year. At this point of time, there are about 2.8 million multiple sclerosis people worldwide. At this point of time, probably close to almost close to 500 million people with depression. A similar number or more with anxiety. Migraine, just over 1 billion people worldwide. Tension type headaches, just over 1 billion worldwide. So what I'm trying to collect and put together is to remind viewers that disorders affecting human brain are very common, almost 1 out of every 3. Given that we are not living alone, we are married to our partners, we have children, almost all of us have some network with us. If 1 out of 3 of us are affected with one of the brain disorders, you could see that how much it is impacting others. So let's park that on a side also. The other important thing is we now know that 90% of the strokes can be prevented, and the significant amount of them can be treated well also. Say, for an example, when people get a mini stroke or transient ischemic attack, if you get 100 transient ischemic attacks, at least 25 of them would go on to develop a massive stroke. So that's an opportunity to pick and fix so that they can be prevented from having a stroke. I don't know whether you had a chance to look at a recent correspondence written by Professor Vladimir Hachinsky from Canada. It's basically 3 paragraphs redefining brain health and talking about health. What he basically say is World Health Organization health means the physical, mental, and complete physical, mental, and social well-being is health, not just mere absence of disease or infirmity. This is what World Health Organization defined as health in 1948, before any one of us were born. I mean, 2 of us. But what he's arguing is that when you look at that definition of health, it automatically reminds you how critically important brain health is. You can't basically talk about mental well-being and social well-being without having a reasonably well-functioning, preserved brain activity or brain function. So what I'm saying is that there is no health without brain health. What I told viewers about all those numbers is this sort of a application, if we can pick some objective changes of brain involvement due to whatever the disease, whether it is headache, disease like multiple sclerosis or vascular event, it gives us an opportunity to pick that disease early and hopefully fix that with the therapeutic armamentariums that we have. The other important thing that I would like to remind viewers is while it is useful for me to see individual patients that I see as a clinical neurologist and address their risk factors and manage them, I can only see one patient at a time. I am human, he or she is human also. So individual risk reduction is beneficial, whereas the community level risk reduction is enormously beneficial. And the preventative aspect, public health aspect, I mean, we are both in the middle of a pandemic. We know how critically important public health messages and interventions are. So what you have created has a huge potential. And I have been telling Professor Vingrys multiple times that we should have a 2-tier system. One tier to use as screening at home by people themselves, and then the second tier at hospitals and clinician levels. Obviously, these things cost money, and we are trying hard to find some money to build those things up. Hopefully, for the next World Brain Day, we may have some good news story to tell on that aspect. Anything that you would like to add to the words that I was rambling thus far?
Tiza, you covered the area from start to finish, and I'm in full agreement with you. The issue of healthcare, as our world population ages, the issue of healthcare, in my opinion, is going to be beyond the health resources of people like yourself and other doctors. It's just overwhelming. We have had quite an interesting response from the British, who their NHS can't cope with the chronic eye diseases. I don't know about other diseases, but the eye diseases like glaucoma, AMD, that need monitoring every 6 months. They just can't cope with the number of people involved. So they're now trying to get systems where they can triage patients who may have changed, but to do it in their own home. So our device is wonderful for that, because you can simply ask the patient to either use their own tablet or use their own PC, what we've found is some elderly patients don't necessarily have a tablet or a PC, but their friend might have one, or their children might have one, or that type of stuff. So it involves a family in their care. And so the concept of triage, the concept of telemedicine, and the concept of home monitoring, I think, is becoming enormous, and it's probably, in my opinion, going to be the way of the future for most disciplines, including neuro-ophthalmology. One of the interesting things that you didn't mention, because we're starting to get a lot of interest in it, is the area of concussion. Concussion affects many young people, and they can have that effect for, a lot of the conditions that you may have mentioned were older, in the older age group. But concussion can occur at a very young age and can affect a person over their life. And we think that using apps will be able to pick up concussion quite well. Our app has 3 forms of acuity, which you will probably be familiar with. One acuity is just a standard high contrast letter chart that everybody's seen in the eye doctor's rooms. The second is a low contrast that you refer to. And the third is an acuity that's called acuity and noise, where there's little black and white spots that are jittering all over the acuity target. We developed those 3 levels of acuity because the literature is saying to us that there are 3 visual channels that detect acuity targets, one being determined by the optics of the eye. So if you become short-sighted, like you may be and I might be, or if you become long-sighted, your acuity goes off, but that's the high contrast acuity. If you start getting retinal or optic nerve disease, like let's say MS, the low contrast acuity goes off. And if you get brain disease, the acuity and noise goes off, because the brain somehow cleans up the image and makes an image out of something that's all jittering and unfamiliar to the eye. And so what we're finding, for example, in that stroke study that you were part of and we were investigated the patients on, we found, this blew me away, I didn't realize this, we found 50% of our patients did not know that they had a vision problem, but they actually did have vision problems. We could test them. They'd have a hemianopia, but they'd have something else. And these patients were not aware of it. These are patients after stroke. And the acuity that was affected most was the acuity and noise, where it had all this little jitter around it, which makes sense because it means their brain can't put together those elements like it used to. While I haven't tested it formally, we're getting some evidence that patients with Parkinson's and patients with Alzheimer's also had difficulty with that jittering, noisy type of acuity target. Our problem has been, as you realise quite well, we can produce that form of jitter on an Apple because it's a very high resolution piece of equipment, but we can't do it on a PC or Android typically. You can do it on Android, but we haven't yet. But you have difficulty in doing it in other media. So our browser-based software doesn't have that included in it because much of the equipment that can be used is not available to it. And let me finish just pointing out, you may already be aware of this, but one of the applications that many healthcare systems are looking at, I kind of alluded to this at the start, with our application, is to pre-test people waiting for doctors' visits. And they're doing this in India. So they've got about 6 tablets that an assistant carries around to the patients who are waiting to be seen by the doctor. It generates the results. The doctor then can interview the patient, and on top of that, they've got the vision results with them, and they can sort of see whether any of this is making sense to them. And so the whole aspect that you're talking about, the use of tablets, the use of modern technology, it's just starting to open up. It's got an enormous potential in the future. Yeah.
Absolutely. I think during last 5 years or so, with the help of a young optometrist, I must have now collected almost 500, 600 patients and really comprehensive material that could easily be translated to 2 or 3 new PhDs. If we went back and analyzed them in depth. And you're absolutely right. I can't imagine if we put these tablets to ambulances, if we put these tablets to emergency department waiting rooms, where most emergency departments in the world, sometimes patients wait, sometimes up to 6, 7, 8 hours, 9 hours without being triaged. In the developed world, you are aware that sometimes patients die while they are waiting because they have not been triaged, not because of anyone's fault. The way that our hospital systems work is for a particular patient to go in, there has to be a free bed. The bottleneck is if we can't discharge patients on time due to whatever the reason, we can't basically get patients in. But whatever the technology that we can build while they're waiting would certainly help to save lives and make doctors, nurses, and other healthcare workers' decision-making process easier. I am very hopeful that what your team has generated will have enough value, and we could even fine-tune things further. So some sort of a screening arm. The main reason that I'm interested in this is, that I'm originally from Sri Lanka, which is the very resource-limited country. And about 10 years ago, while the population of Sri Lanka is very much similar to Australia with 23 million or close to 23 million people, they had almost like 60 million smartphones in that country. So the almost like 2 or 3 phones per person. So you're absolutely right. The world has changed, and people do spend whatever the little money that they have on gadgets, then we have to find a way to convert them to some sort of a community level health screening and then intervene. I think we talked.
Our work. Your listeners may find this interesting. You may find this interesting as well. Our work with patients home monitoring. We've had patients monitoring their eye disease. Some of them got glaucoma, some of them got AMD. Now for about 12 months. What we find is that patients doing it at home produce a lot more unreliable outcomes. Now, when I first started this, I thought that's not a good thing. An unreliable outcome. What ends up happening is the patients, I'll give you an example. We had this gentleman, he was an 85-year-old gentleman who had glaucoma, and we were watching him, and he was about 3 months in to home monitoring, and the concept was he was doing it every week, and we agreed that he'd do it on Monday at about 8 o'clock in the evening. So we would send him a text message on his phone. I would say, Frank or Fred or whatever his name was, your eye test is due. Would you mind doing it? So he'd invariably start doing it. And after about 3 months, we found his results were nonsensical. He couldn't see anything and went to blank. And so there's only one option, and that was that he'd gone completely blind in both eyes. We thought, well, we'll wait and see what happens next week, and we got him to do it again, and exactly the same thing happened. And so we got a little bit concerned, and we rang Fred, and we said, Fred, you were previously could see quite well, and all of a sudden we've had 2 weeks where you can't see. What's going on? And he said, oh, a friend of mine comes over, and it so happens that I let them in, and I make a cup of tea, and I don't know how to turn the thing off, so I just let it keep going. And so, in fact, it wasn't testing anything. So the home environment or getting patients to do tests themselves can produce unreliable tests. But because they can do it so often, they can repeat it. They can do 3 or 4 or 5, one every day. You find that you get good data in the end. I guess it's a little bit like patients doing their own blood pressure or patients doing their own insulin. There'll be variability in the outcome. But the actual, yeah.
On a positive note, you are aware that I am using MRF app to monitor idiopathic intracranial hypertension patients' vision at home. Pre-COVID time, one of my patients was wanting to do a Europe tour. Her ancestors were from Italy, and her visual acuity was sort of a touch and go. But she kept emailing me with acuity results and fields. So I got through about, I think, 6 or 7 blind spot records and field records and acuity records throughout her trip. So she would she would flick the images. They would come to me as an email, and I would email her saying reassuring me as well as optometrist both. So I think it kept all 3 of us in peace, basically. She was having a fabulous holiday, and we were happy that she was not putting on weight or losing her vision.
That's terrific. That's a good news story.
So
and that's also good use of patient home monitoring or self-monitoring of their vision. We've come to learn now that an abnormality once is not an abnormality. It could just be finger trouble. It could be the person didn't respond properly on the keyboard. It could be they got distracted. Their children ran around and they had to attend to that or something of that nature. When it's repeated twice, what happens is we now have the process automated. So if we get 2 abnormalities, one after another, we send a polite email to the person and we say, look, you've done a really good job testing yourself every week, but we'd like you to do some testing every day for the next week. So they do 7 tests in a row. And by the end of that week, we have a good idea as to whether that person, actually by about the 3rd or 4th day, we can tell whether that person has actually really changed and needs attention, medical attention, or hasn't changed. And with the system the way it sits, if the patient has changed, if we think there's more evidence than not that they've changed, we then notify the doctor who is the patient's doctor, and we'll leave it up to them to see whether they want to review the patient, have them come back in or whatever. I guess if your patient's on a trip to Italy, it's a little bit harder to do, but they could probably go to a local hospital or something if that's the case. But yes, that's the sort of medicine that's being opened up. I'll share with you another story. And it's not in neuro, but it's regarding one of my colleagues who lives in Queensland. They're in a rural setting in Queensland. And Queensland, for those people who are not from Australia, is has got some very large areas, remote areas. And this person had a diabetic patient who'd come in from a farmer who'd come in from the country. It took him about 3 hours driving to get in to see the optometrist to have the diabetes checked. And they were talking about the app, and the farmer said, look, if I could do this at home on my farm and save myself 3 hours driving in to see you and 3 hours going home, and then all the time I spend in the city here. This is fantastic. So in Queensland, there's another good example. This person is now using the technology to do telemedicine with this farmer. And while their vision's not changing, there's no real compulsion to bring them back urgently. And as soon as their vision does change, then the stakes are up, and it's a bit like they've triaged and they've decided we need to review you quickly. Yeah.
What a great story. That would probably be a nice segue to move to the second topic. As you are aware, I have been heavily involved with this World Brain Day campaign since the inception in 2014. Basically, what we normally do is we select a particular disease every year, and then we partner with another global advocacy organization, and then we advocate on 5 key themes to basically improve access, improve care, improve treatment, improve education, improve awareness, pretty much with the notion of promoting better brain health on the back of that illness per that year. This has grown over the last 8 years. This year, our expectation is to reach out to well over 100 million people, the campaign material. Basically, from March onwards, a group of us get together globally, and then we create contents. We create a slide deck, we create social media posts, we create a press brief, and then we do live webinars targeting the different parts of the globe. As a clinician, scientist, and academic, although you did say that you are retired beginning, I know that you are not retired. You still, I can't basically get hold of you every time when I ring you. I have to sort of text you and ring you multiple times to get hold of you. That's that's a sign of non-retirement. So how excited are you to see that neurologists have moved beyond their comfort zones, and now they are advocating globally in a synergistic way to put all forces together to promote brain health on the back of this sort of a campaign?
Look, I would hope that one element of brain of the brain is that the eye and vision processing takes up such a large volume of brain matter. I can't remember the figure off the top of my head, but I think it's something like 2/3 or 3/4 of the brain is
almost close to 90%.
Yeah. Well, yes, there you go. To eye movements, to vision, to visual processing, to attention, so to memory, and so on. So it's a huge amount, and vision is a very important element. But as I said, I'm also impressed by the fact that of those patients that we had who had stroke and who had substantive losses, both either in their motor or sensory elements, half of them were not aware of having a vision problem. And so there's something more complex about how can this organ, and I guess I've covered it in the way, because it's got, as you say, 90% of the brain dedicated to vision processing. Maybe alternate pathways open up when you get things like degenerations and stroke and other things happening that allow the person to feel as though they're seeing well, but in fact are not seeing well. And it's those people that need to be counselled. But let's face it, let's just take, we've talked about perimetry a bit. Let's take perimetry, for example. The tests that commonly one wants to use to do perimetry are usually expensive. They're from $30,000 to $50,000 US. That's not cheap. And when you start talking of a country like Sri Lanka, it becomes almost impossible to purchase multiple of these units and put them into hospitals. Whereas if you get a tablet, I can get a reconditioned tablet here, a good tablet, for about 400 Australian dollars. And so, against 40 or 50,000, that's a significant saving in money. But then people can start testing vision and seeing whether these things are effective or not. You raise an important topic at the very start, Tizza, and that is on eye movements. And we haven't pursued eye movements very much because my interest was more in the visual sensory elements. But now, both Apple and Samsung and are producing good eye tracking software. We have just recently created, we've used a commercial eye tracker that's a gaming eye tracker, so that they use it, you put it at the bottom of your TV and it can watch your eyes as you go left and right. And so those technologies will probably be where we'll develop in the next year or two. And you'll probably find that eye movements, as well as visual sensory elements, as well as higher cognitive elements, will be available to ophthalmologists, neuro-ophthalmologists, nurses, doctors, anybody who needs to use it. We're reluctant to allow that type of information or that type of testing out to the public, simply because we feel that a medical person has to be in charge of what they do with the information at the end. There has to be some sensibility, because otherwise they'll go to Dr. Google and Dr. Google will give them the wrong answer.
I agree. I think you brought concussion to the topic. Last year, I sort of tell my residents and others, despite I have been medical folk for almost close to 3 decades, so moving into 3rd decade now, I told everyone this is the truth, that while I have always been quite inquisitive and curious on how illnesses occur and what the sort of disease mechanisms were that drew me to medicine long time ago, I think last year I learned much more than any other years on the back of the pandemic and the large number of patients who came through our hospital. You do know that we were the hardest hit last year. And the reason that I'm saying this is we are in the middle of a pandemic. We have a large number of COVID-19 infected and recovered people. We ourselves realize that the potential for COVID-affected people to have long-term neurological problems is real. It seems to be anything up to 30 to 60%, whichever the paper that you read. What we have witnessed is close to 30%. Even if you get 30% out of 500 million people, that's a huge number. So I think the brain disorders and involvement of brain is going to be quite fascinating in time to come. And the concussion that you mentioned, the humans are sports mad, the animals, they're social animals. And we also know that things such as domestic violence has gone up, skyrocketing as a result of all the social and other things that happened as a result of this pandemic. So that means we do know that it's very clearly documented that domestic violence is indeed associated with concussion. So that would add further the brain health threats. So these sort of things.
And road trauma as well. Road trauma is obviously another significant impact. Yeah,
absolutely. So what we are both trying to say is how critically important for us to keep asking questions and keep improving things as best as possible. Yeah. Because as I said before, there's no health without brain health. You cannot talk about complete mental and social well-being without having well-functioning or preserved brain function, irrespective of threats that are happening. My last question to you, Algis, is your journey is quite fascinating. You basically showed the world that if you have the desire, if you have the will, sky is the limit. Whether you are a pilot who had been asked to retire. You can start learning at any point. Basically, that's what I'm trying to say. And you basically debunk the myth that you cannot be an academic unless you start very early. You didn't start very early, but that didn't make you second to anybody.
Yes. I started when I had close to. I think we've got 3 children with my wife, and I think we had our third as I was finishing my PhD. And so we traveled the world together. I did postdocs with my wife. It also modified my whole take on academia and clinical research. I have what I think is a very healthy outlook that people should research. The point I want to leave you with, Tizza, is how is the world going to cope when brilliant people like yourself and other doctors are distracted to be purely 100% clinic because the clinics are so busy and they can't spend time doing research? That is a real challenge for all our societies, because it's really the research that takes us forward and takes us all those steps into the future. So I encourage all of those people who are listening and all those others that work in neuro to try and develop a good, healthy attitude to their clinical research.
I totally agree. I think that's a very good message to youngsters. I think the life is not all about making truckload of money. I mean, pandemic has reminded us you can't eat money. You can't go nowhere, even if you had money. So you need some money to put bread and milk on the table. I agree, but you don't need a lot of it. So you should try and find some sort of a balance to add important clinical research, because we are not done yet. There's a whole lot for us to do, and that would only be able to be done by the being curious and keep asking questions. And the other thing is, what I learned by working with you is you are an excellent collaborator. Tell our youngsters why it is important to collaborate and why we do say that if you are a super competitor, you should be a super collaborator.
Yeah, very good.
You agree with what I said, that collaboration is the key to find solutions?
Yes, I think in my pilot's training, I was taught that there's the captain and the first officer at the front of the plane, and there are the airline crew, the assistants, the hostesses, and so on. But the crew works as a team in every single flight. And there are some amazing stories of flights that have survived when all of their electronics is gone and all their electrics is gone. And it hasn't been just the one person that was left to make the decisions. Usually in those circumstances, the captain solicits opinions from others and then makes a formed decision based on their experience, which is what the captain's there for. And so that's a perfect example of collaboration. I had it all through my life in flying. I came into academia and I had it as well. And you're quite right. There are some people who don't quite understand collaboration to that extent. They tend to scoff it. And I wonder whether our competitive grant system has created this type of competition that people are now looking at collaboration in what I think is a very unhealthy way. It needs to be more open. It needs to, if I can help you, I will. And if you can help me, that's good. And we'll help the next person. And that's the way humanity benefits, not just an individual.
Absolutely. I think that's a nice, nice way to end this long chat. It's it was a sheer joy to have this conversation with you, Professor Algis Vingrys. We wish you all the very best, good health and happiness, and we look forward to seeing further development and advancement of really useful things that your teams have put forward. And as you know, our group is an immense beneficiary of some of this work, and we will try our very best to take them worldwide as they continue to unfold. Have a good night, stay safe and stay well. And I look forward to catching up with you face to face one of these days when this virus is behaving in some sort of a normal way.
That'd be terrific. That'd be terrific. Thank you.
Take care. Bye.